Hi, my name is Nicole Parrish. I'm an assistant professor at the Johns Hopkins Medical School, and I'm the director of the Mycobacteriology Laboratory for the Department of Pathology. I've spent about the last 25 years working on mycobacteriology. In particular, my specialty is tuberculosis, but I'm also interested in non-tuberculous mycobacterial disease, and in particular, I'm going to talk to you today about some recent evidence that we have that shows that MAP can adapt to anaerobiosis using an in vitro model. And then one of my colleagues, Dr. Neil Goldberg, is going to talk about a recent case that we had in terms of how we applied what we learned from the anaerobic model to treatment. So the title of the talk is MAP, In Vitro Adaptation to Anaerobiosis, Differential Susceptibility to Antibiotics and Implications for Therapy. Okay, so first of all, what I would like to do is talk about mycobacterial dormancy, also known as latency. Most of this information comes from what we know about Mycobacterium tuberculosis or from the BCG vaccine strain. What we do know is that Mycobacterium tuberculosis and BCG both can adapt to an anaerobic state where they reduce their metabolism to a very low basal level in order to adapt to an anaerobic state. Organisms can persist in this state for years to decades in vivo, and reactivation can occur due to a number of reasons, including waning of immunosurveillance. So it means that although the organisms are not actively replicating, they are still anagenically stimulatory for the actual immune system. And that's important to remember because you cannot cultivate them under this scenario. So latently adapted M. tuberculosis has been shown to be non-cultivable. So you can have a patient that has dormant Mycobacterium tuberculosis and you cannot find evidence of it anywhere. You can't cultivate it. You cannot detect it by nucleic acid amplification methods at all. And it's not susceptible to standard antimycobacterial agents. The main reason is because most of the agents, such as isoniazid and rifampin, require actively growing processes to be susceptible to the drug. So that's one of the main reasons that therapy for Mycobacterium tuberculosis takes such a long time, many times months to years. And it's because the organism in vivo occupies multiple states simultaneously. So you have aerobically actively growing bacilli. Then you have those that are shifting down into this anaerobic state. And then those that have become completely latent. So you have a spectrum, and that's why it's very difficult to kill it. So I want to tell you a little bit about the Wayne model of non-replicating persistence. This is an in vitro model that was developed for Mycobacterium tuberculosis. And it's a way for us to establish the non-replicating persistent state in vitro by gradually withdrawing oxygen over a specified period of time, which allows aerobically growing MTB to gradually shift, and that's important, gradually shift into an anaerobic state. If you withdraw oxygen too quickly from these cultures, what happens is it dies. So this happens over a period of days, and it allows the metabolic state and the transcriptional adaptation to anaerobic conditions. It's been used extensively by many labs, including our own, to screen drugs to see if we can kill anaerobically adapted MTB. And from here on out, I'll talk about them as non-replicating persisters or latently adapted organisms. It's important to remember that under anaerobic conditions, drugs such as isoniazid and rifampin are actually not effective at killing those organisms. Again, because there's no active process ongoing that is subject to the target mechanism of the drugs. What's interesting is in an anaerobic state, MTB is susceptible in the in vitro model to metronidazole. And metronidazole, as everyone knows, is an anaerobic drug. So in this particular slide, there's a diagram that illustrates the Wayne model and how it actually shows the adaptation over time to anaerobiosis. So what you see in the pink line is the actual colony forming units. These are the viable counts in a culture over time, and then the blue line is actually indicating the optical density of the culture. What you'll see are two arrows, the F and the D. F indicates where methylene blue starts to fade. So this is the point in the culture where oxygen is starting to be depleted. So that's indicated by the F, which stands for fading. The D indicates where the culture has become completely decolorized. So there is no oxygen remaining in the culture at all. And what you'll notice is that the pink line levels off at a point before it actually hits decolorization. And that's because once the organisms get to a certain point, which is indicated by F, they enter non-replicating persistence stage 1. And that's where the organisms kind of stop dividing, but they continue to plump up. So you'll see that at that point, F, the colony forming units do not increase anymore, but the OD continues to go up slightly until you reach point D. And that's because the organisms, instead of dividing, they actually plump up and they go into the stasis mode where they become latently adapted. This is important because when we were wanting to do this same testing with MAP, we wanted to see if we could duplicate the lines on this graph. Because this has been done very, very well for MTB, and it's very well characterized. So what about MAP and latency? Why in the world would we think that MAP could possibly adapt to anaerobiosis? And it turns out that there are several lines of evidence emerging that indicates that this may actually be the case. So MAP has been shown to survive in the environment, in industrial waste and sewage effluents, which are very anaerobic. And then also recent transcriptome studies with MAP obtained from tissues have shown significant shutdown of major metabolic pathways with upregulation of major areas that are related to latency. The authors in that particular study suggest that MAP survival in vivo may be related to immune evasion. And in that case, establishment of non-replicating persistence and intracellular survival within macrophages would actually be key. And that would not be that dissimilar from what happens with Mycobacterium tuberculosis if you think about it, because Mycobacterium tuberculosis enters into a latent state once the immune system walls it off in a granuloma, and the center of that becomes very anoxic. So it's also been postulated that MAP may establish a latent infection in most individuals, as does MTB, resulting in infection without active disease, and then possibly able to be reactivated later in life or due to some sort of immune suppression. So that has not been proven at this point, but it is at least something to speculate about, considering what we're finding in vitro in terms of the adaptation of this organism to anaerobiosis. So at this point, we had a lot of questions. Because of my familiarity with MTB in terms of how it adapts to latency in vitro, we wanted to ask two questions in particular. One, is MAP capable of adaptation to anaerobiosis in vitro using the Wayne model of non-replicating persistence that was developed for MTB? And then the second thing is, if MAP is capable to adaptation to anaerobiosis, as TB is, then is it susceptible to the same drugs under both aerobic and anaerobic conditions, which if it's like TB, it would not be. So now I'm going to show you some data from a paper that we recently got published in the journal Gut Pathogens. The title of it is Anaerobic Adaptation of Mycobacterium avium Subspecies Paratuberculosis in Vitro, Similarities to M. tuberculosis and Differential Susceptibility to Antibiotics. And in this particular figure, there are 6 graphs. And what you'll notice is that the lines and the bars look very similar in slope to what I showed you earlier of the Wayne model, and how the CFUs, or the viable counts, go up to a certain point where oxygen is depleted or starting to be depleted, and then they level off. And then the optical density continues to increase until you reach complete anaerobiosis. And as you can see, there are 2 ATCC strains of MAP, and then 3 bovine-derived strains labeled B1 through B3, and then BCG, which is the vaccine strain of Mycobacterium bovis used as a control here to demonstrate that the slope of the lines and the graph and the bars on all of the graphs actually mimic what we see for Mycobacterium bovis BCG. So in particular, I'd like to point out with this particular figure that in reality, this is very suggestive that not only can MAP adapt to anaerobiosis in vitro, very much like TB and BCG do, but it does it in very much the same way. It takes about the same amount of time, maybe just a slight amount longer than the other two. Usually for TB, it took about 10 to 12 days. You'll see from these graphs, it's on the order of 14 to 16 days for most of the para-TB or MAP strains. But I think it's very interesting that the graphs look so similar between the organisms, between the species. Even more important, if you look at this next table. So this table basically shows you the minimum inhibitory concentrations to various antibiotics under both aerobic and anaerobic conditions. And so under aerobic conditions, you can see for all of the MAP strains tested that the MICs to various drugs, rifampin, rifaximin, amikacin, ciprofloxacin, clarithromycin, ethambutol, gentamicin, metronidazole, mesalamine, and salicylin. They're very variable for the most part, which is typical for what we've shown as well as other investigators have shown in vitro, that variability between strains in terms of MICs to different drugs is very common. But then when you look under anaerobic conditions, we actually went three or fourfold or higher than the calculated MICs for all of these drugs under anaerobic conditions, just to see what the range would be. And what you can see is that under anaerobic conditions, really the only drug that works is metronidazole with an MIC of 12.5. Under aerobic conditions, metronidazole does not work at all. If you look at strain ATCC 19698, which is the type strain, you can see, for instance, that rifampin under aerobic conditions has an MIC of 2, and under anaerobic conditions has an MIC that is greater than test range, which is the top of the range that we tested at 8 micrograms per mil. So this really begs a question, because even though MAP has not been definitively proven to cause Crohn's or any other inflammatory bowel disease, the thing about it is that you have to think about is if it's anaerobically adapted in the gut, then standard drugs that we may think about using that have aerobic activity won't do anything to anaerobically adapted organisms if they should exist in the gut. Which raised a lot of questions in terms of what do we do about therapy? Have we been thinking about this in the wrong way? Because if you have 2 different populations or more of MAP adapted in the gut, so aerobic and then anaerobic, and then those that are adapting, so they're in transition states. If they're in the gut and you're using only aerobically active drugs, then is that really the right approach? Because if you have anaerobically adapted organisms, it's not going to help. And so what about combination therapy using aerobic and anaerobically active drugs against MAP? And that's where I would like to turn the talk over to my colleague, Dr. Neil Goldberg, who will tell you about a case that he was involved with, and he used a combination therapy with this aerobic versus anaerobic idea in the background.
Thank you, Nikki. Hi, my name is Neil Goldberg. I'm a private practitioner in gastroenterology in Towson, Maryland, and a clinical assistant professor of gastroenterology at the University of Maryland. And Nikki and I hooked up over 10 years ago to start studying whether MAP played a significant role in Crohn's disease, and have published a couple papers along the way. And Nikki alluded to our most recent paper. And that data segues into how we decided to treat this patient. And the paper that I'm referring to was published in January of 2015. And it's entitled Treatment of Refractory Crohn's Disease and Pyoderma Gangrenosum with a Combination Regimen of Rifaximin, Gentamicin, and Metronidazole. And we decided to use this combination precisely because of the data that Nikki just presented. But in particular, gentamicin was added to the mix because, number one, the drug is not readily absorbed from the gut, so high concentrations are achieved within the gut without much risk of affecting the kidneys. And anecdotally, gentamicin is used for food poisoning in China, which is where I actually got the idea to use it orally. And number three, gentamicin was initially developed as a possible tuberculosis drug. Rifaximin and metronidazole have both used with some success in helping symptoms and occasionally placing Crohn's patients in remission. But I did, and in consultation with Nikki, we thought that using the three drugs together had a better chance of placing this patient, of whom I will speak, in remission. The patient is a 44-year-old Caucasian female who presented with a 10-year history of biopsy-proven Crohn's disease involving the terminal ileum. She also had a 3-year history of severe pyoderma gangrenosum. On presentation to University of Maryland St. Joseph Medical Center, she had severe right lower quadrant pain. She had active pyodermal lesions. She had no fever, chills, or rigor, no blood per rectum, diarrhea, nausea, or vomiting, and no weight loss. The pyoderma had been sequentially treated with thalidomide without any success, Remicade 10 milligrams per kilogram with only minimal success. Subsequently, she was switched to a Humira induction dose and then 40 milligrams IV Q2 weeks with no change and persistence of lesions up to the time of admission. On the next slide, you'll see the medications that she was on in addition to the Humira. Delzacol, 3,600 milligrams per day. Vitamin B12, 1 milligram IM monthly. Vitamin D, 50,000 units per month. Omeprazole, 20 milligrams daily, and a probiotic twice daily. The physical exam was remarkable for some fullness and tenderness in the right lower quadrant without any distension. Her labs demonstrated a white count that was normal at 7,500, her hemoglobin 11.2, and her sed rate was moderately elevated at 37. On this slide, you see the worst pyodermal lesion on her shin from the time of admission. We decided to use the three drugs I mentioned before. The doses were gentamicin 80 milligrams, rifaximin 550 milligrams, and metronidazole 250 milligrams, all given 3 times a day. Within a couple days, the patient noticed that her lesions, some of her active lesions, tended to be getting a little bit smaller. Within a week, there were no new lesions, and the disease seemed to have been arrested completely. At a week also, her right lower quadrant pain and fullness had resolved. At 4 weeks of treatment, there were no active skin lesions present. She had absolutely no abdominal pain, and her abdominal exam was completely normal. This next slide gives you a head-to-head comparison of before and after therapy, which we believe is quite dramatic. And these slides are in our paper from January of 2015. After 3 months of triple antibiotic therapy, follow-up colonoscopy was performed. There was absolutely no evidence of disease in the colon or in the distal terminal ileum going up 20 centimeters above the ileocecal valve. Conclusions. MAP can adapt to anaerobiosis in vitro using the Wayne model developed for Mycobacterium tuberculosis. Such adaptation results in differential susceptibility to various antibiotics under aerobic versus anaerobic conditions. Aerobically active drugs have no activity against anaerobically adapted, non-replicating persistent bacilli, and vice versa. Mixed populations of MAP are likely to exist in vivo as they do in MTB. Thus, combination therapies containing metronidazole and aerobically active drugs should be considered. In the current case, it is not known whether MAP was present. Thus, the dramatic remission could have been secondary to the antibiotics altering the gut microbiome. Since rifaximin and gentamicin are not absorbed from the intestine, each drug would have been concentrated in the gut, and the metronidazole penetrates the tissue, and the combination may have led to overall improvement of the patient. This dramatic response warrants further investigation of this antibiotic combination as a treatment for Crohn's disease.